So welcome. As you may have noticed something, we're dropping that 1 minute countdown. That was done at a request of a viewer, but w- we've got a lot of other viewers that we're trying to keep happy as well and trying to serve. So that's one of the changes that you'll be seeing over the next few weeks. We're bringing in some folks, taking a hard look at our YouTube channel and seeing how can we serve our population better. Today, we're going to talk about clearly. We've heard it multiple times. People come in and say, you know what? I've got that new AI driven CT angiogram. It's great. It's the best thing that's ever happened. Really? I've taken a look at this multiple times, and yeah, there's some advantage, but there's still some very significant disadvantages. So stay tuned and we'll talk about that. Another thing we're going to be talking about is ApoB and LDL. You know, you hear it a lot on other channels. It's all ApoB. It's all ApoB. Let's slow down and really ask that question and dig a little bit deeper. So that's some of what we're going to be doing today. Jesus, you want to talk a little bit more about the intro?
Sure. So when we talk about this ApoB and LDL, probably I should have put it on the title as well. And we're working on improving our titles as well. But we're talking about the new evidence from David Feldman and the lean mass hyperresponder study. He was in a low carb conference last month, and he brought up what Dr. Brewer thinks it's kind of a bomb. I agree with that. We were not as excited apparently last week about that, but it's really interesting stuff, and it might change the way traditional medical community sees LDL and ApoB. Hopefully, will be the first stepping stone to that purpose.
Let
So
me jump in. Let me
yeah,
jump in and
go ahead.
interrupt and say this. What we talked about last week was a group of 100 people,
Yep.
average LDL 260. And if you're sitting there listening and thinking 260 is not bad, you're probably thinking of total cholesterol. An LDL of 260 is 1 in 1,000. And we've got an average of 100 people with that. One of the questions is, did they must have had huge amount of plaque, right? No, that's not right. And again, we'll talk a little bit more about that as we get into the show today.
We talked about not spilling the beans on the first 30 seconds, Dr. Brewer.
I'm a bad bean spiller. We know that. But I still think it leaves a lot to be figured out. Why did these people not have plaque? What's going on?
All right. So we're going to talk about that. For those of you who are familiar with lean mass hyperresponder, I think this is information you will love to know. If you're not familiar with lean mass hyperresponder, stay tuned. We're going to talk a little bit more about that so you are familiar with that. And maybe you are one and you just don't know it. And the short topic CTA and the AI, yes, this is what Dr. Brewer is talking about on the Clearly side. So it's basically a computer tomography angiogram using artificial intelligence to interpret the results. It's the new kid on the block on regards to detecting plaque. And it's supposed to tell you if you do have soft plaque or you have just calcified plaque, and if that's going to cause you a heart attack or no. So very interesting stuff because technology is developing every day, but there are still things that you might be careful about when interpreting that. Last week we talked about resistant starch and if it does any good to frozen your rice or froze your other sources of carbs and see if that will impact your glucose levels on a lower level. I'll say go watch that video after this one, but Dr. Brew will tell you no, but still go see the video so you can understand why. And hidden risk factor for premature aging. We're talking about especially sodium levels when you are around 20, 30 years old. Something that a lot of the medical community doesn't take a look at, but it appears to be a factor to be related with premature aging. So take a look at that as well. And we talked about keto to plant-based according to the American Heart Association recommendations. You'll be surprised to see that they uh, put low carb diets on the lower tier of recommendations according to them. So very interesting stuff. You should go ahead and take a look at it if you're interested on those types of topics. Shout out to our website, prepmedhealth.com, if you're looking to get a more in-depth and personalized opinion on your specific condition. This is something that we cannot do on the YouTube show. We cannot do that just by messaging. But of course, we would love to have you as a patient. Go to the website, book an appointment to see the PrepMed team if that's something that you will be interested in, of course. I'll yield to Jeannie so he can present herself and talk to us a little bit more about the OGTT and insulin response.
Good morning. My name is Jeannie Shanholzer, and I'm one of the nurse practitioners at PrevMed. I am trying to help educate our patients on YouTube and in their visits about some of the labs and some of the tests that we require or that we recommend. So I will talk to you a little bit about the oral glucose tolerance test with the insulin response. We try to talk about this quite frequently, and we talk about it many times a day because we want to make it successful on your first attempt. So essentially, we want you to go to the lab while you're fasting. When you get there, they will have you drink a sugary drink. It's about 75 grams of sugar. And then but prior to drinking that drink, they're going to draw some blood. So you'll get to the lab, they'll draw some blood. At that point, they should be drawing the fasting blood sugar along with the insulin response. Then you'll drink the drink. And then at 1 hour, they will again draw 2 vials of blood. And then at 2 hours. And while you're there, we like you to kind of sit still, not walk around, because that will, that won't give us the most accurate reading. And we want to see how your body's responding with making glucose, with insulin, with all of it. So it gives us a good picture of your metabolic health, probably one of the best pictures. One of the things that I want to say, and Dr. Burr, do you need to jump in? Because I feel like you do.
No, I'm just listening. But well, now that you shouldn't have asked. So when you get a chance,
she saw you holding your breath. You can see your vein right here starting to popping up, trying to say something. Yeah.
So you're going to tell us what the most common problem is and how to help avoid that, right?
I am. I very much am.
So let me be quiet.
Do you want to share it? You can share it if you'd like.
No. Let me be quiet and let you do that.
Okay. So the most common problem, then there's I'm trying to give you all the little things that we see in one slide. So the most common problem we see is that the insulin response is missed. So then people have to go, often they have to go back and repeat this, and this takes 2.5 hours. So we don't want that to happen to you. So when they're drawing, the first set of labs, they're going to draw a lot of tubes. So it's hard to know if that insulin response is in there, though you can ask them. But then at the 1 hour, you should see 2 test tubes being drawn. And then at the 2 hour, and I think Dr. Brewer even had the issue when he had his own labs drawn that they did not draw it correctly. So it's just something we like you to be aware of, because knowledge is power, especially when you're getting procedures done. And if the lab doesn't know, they can ask a supervisor or what have you. Again, they do glucose tolerance tests for pregnant women all the time. They don't do the insulin response with it. That's what the part is that's a little more tricky, but it's easily handled. And we see it. I actually will tell you, with our education of patients, we are seeing it come back more and more frequently now, and it's done correctly on the first time. So that's a very good plus. That's the time we spend educating is helping. Another thing about insurance coverage with this, it's hard to know if it'll cover. Most of the time it'll cover the OGTT, and sometimes it won't cover the insulin response. We're not sure if that will be the case with your insurance. So again, we would ask you to ask the lab, check with your insurance. That would be the final say on that. And that should be helpful. So is there anything that you feel like I've missed on that? And we do usually recommend this test yearly. It's not a every quarter test, it's a yearly. I do just remembered I did forget something on that. There's stuff about carb loading versus non-carb loading. We've determined it doesn't make that much difference, meaning you eat a lot of carbs the day before you go have the test or 3 days before you have the test. We've talked about this before, and we've determined it doesn't really make that much a difference whether you do that or you do not. So that's not a necessity for people to do, because a lot of people who do not eat a lot of carbs do not feel happy about eating them for 3 days prior to this test. Did I miss anything?
I don't think so. I'm going to get back up epidemiologically, a public health perspective. Why? Why are we doing this? Because nobody argues that at least a third of prediabetes, diabetes is missed. Some of us believe that 90% of it is missed. Nobody argues with the facts. They've been demonstrated by Mayo Clinic, then Harvard, and others. Originally from guys at Hopkins. 3/4 of primary care doctors that are responsible for doing this don't know how to diagnose prediabetes. That we're talking family practitioners, internists, cardiologists. The next thing is, by the time you get so how is diabetes diagnosed? Most doctors will tell you, well, I diagnose it with hemoglobin A1C. And usually that's not the case. That would be better than the reality. It's still not perfect, but the reality is that the vast majority of diabetes is picked up on a fasting glucose. Here's another reality. If you look at the number of people who already have tissue damage to their eyes, their kidneys, their nerves, it's between 1 and 2/3 by the time they get that diagnosis. Well, is it because we're diagnosing it late? Because we certainly are. Or is it because tissue damage happens even in the pre-diabetes state? I suspect it's both. So it's very important to know what your carb metabolism is from the beginning. Now, a lot of people will say, I'm fine. I do a HOMA IR. HOMA IR is still a snapshot. And we've used that analogy multiple times. We can take a still snapshot, a still image of me standing in front of a bus. It's not until we actually take the movie that we realize the bus is about to run over me. And that's exactly what's going on with most of us, unfortunately, in terms of carb metabolism, prediabetes, diabetes. That's why it's being missed. Our medical community does not know how to diagnose it. And until they learn, they're not going to know how to manage it. So that's a huge part of what we do on this channel. Thank you for letting me go on that rant.
Absolutely. So again, it's the most important test that we order, and it gives us the best indication of what's going on with your blood sugar and your insulin, like Dr. Brewer was talking about. So we just like to make it so that you're educated, and then when you go, the process is smooth and easy, and everyone's happy. So that's all I have on that. Jesus, unless you have anything to add.
Technicians make mistakes. They are not used to do this test, even though they go to their help desk and they will get the wrong information about how to get this done. And to us, having an OGTT, it's important. It provides a lot of information. That's basic for us. Having it with an insulin response is even better, because you can have people that have a basically normal OGTT, but the insulin levels are going through the roof. The pancreas is working extra time, and it's with extra efforts to keep that blood glucose in check. And even high insulin can create damage to the vessels. So that's why you want both things measured, and you want both things measured at the same time.
And on a practicality basis, I mean, I've been a nurse practitioner for 24 years. And the first time I've ever seen an insulin response ordered like this is when I started working here. So,
yeah.
And if I could explain a little bit more, the reason we want that is we need to know, first of all, when I said a moving picture, what we're actually doing is you're taking the glucose, the fasting glucose, and an insulin level. So what does it take? What is my fasting glucose level? If we already know if it's 100, that's in the prediabetes level. Clearly, if it's 110. The standards agree, depending on which standard you look at, over fasting glucose over 120 or 125 meets the standard definition of full diabetes. So the other thing that an OGTT does is it takes those, it gives you that sweet, it challenges your glucose metabolism. They give you 75 grams of glucose, and then we watch your blood sugar at 1 hour and 2 hours. Now, the insulin response is basically looking at insulin as well every time you get a glucose response. As Jesus mentioned, it happened to me. I went to a lab that I trusted, a draw site, and I got distracted looking at making some business calls, and I looked. On the third blood draw, she was drawing all of my insulin studies. And I said, why did you do that? Because we want to know one at each time we get the glucose. And she said, well, I called the lab help desk and they told me to draw them all at once, all the insulins at once. And that's pretty common, unfortunately. We went to the lab and could not get much help from them. So as Jesus said, you've got some of this error process systematized. How do you deal with it? Just as Jeannie said, we're getting really good results when the patient describes what's going on to the lab tech before he or she draws the bloods.
You should have started that with what Jesus tried to say it was.
Repetition is critical. It's very important. So I think that's one of the advantages of having more than just one of us on the show, getting repetition in different words.
No, I agree with that. I'm just teasing you.
And I know we tease you about your English, but I think I've always said your English is far better than my Spanish.
There's one, I think it was D Dutton at some moment that said, "Hey, Dr. Jesus is a great teacher." I'm cherishing that comment for prosperity.
Well, you should.
Más o menos.
Okay, so it's starting for the short topic for today. Wanted to bring you this as an example of computed tomography angiogram report, the traditional one. So this is an example of what you will get. So you go into the testing place, you ask for a CTA. They will put you. They should be checking up on you, physical exam, and making some questions about your medical health, of course. Then they will put you on this bed and they will inject some dye on your vein or on one of your arteries to put some light on whatever they want to see. So they put you in the computer tomography machine and they will scan your chest, your heart, to see how that dye flows within your coronary arteries on your heart. And this is an example of the report they sent. So this was made to a 65-year-old who had a history of sleep apnea. He was on a CPAP, and he had a calcium score previously of 180. The calcium score, the CT, is basically the same thing, but without the dye on your veins. And the total calcium score on this stage was 180 as well. This was made like 4 months out of each other on the lab's time. They found coronary artery plaque involving 4 segments. There was non-obstructive coronary artery disease according to them. And the CAT-RATS is just a type of a scale they use to measure the burden of plaque on this one. But as you see here, it doesn't say anything specific about non-calcified plaque or calcified plaque. Some reports do that, some reports don't. And if you see these CTA report, they are really, really focused on if there's obstructive plaque or not. So that's why we recommend more CIMT rather than just standard CTA, because you can encounter reports like this when you're trying to see if you have soft plaque, and it turns out they don't tell you.
That's not good.
Now, what happened next is clearly the company saw this as an opportunity. So they say, okay, we're gonna do CTA angiograms, but we're gonna now use artificial intelligence to measure all those components and provide a more specific, in-depth analysis. So this is a report from the same patient, same folks, 65 years old, male, and this is the summary. So atherosclerosis, meaning plaque on the vessels of the heart. They found 382 millimeters of total plaque. This is what it got caught my eye, Dr. Brewer, and I don't think I was completely aware of this report until we saw it. Low density, non-calcified, 0. And I think when they say low density, non-calcified, there's a couple of articles out there. They are referring to hot plaque, soft, unstable plaque.
Mm-hmm.
Then you see non-calcified, 380 18 millimeters, cubic millimeters. That's to us, if you see a CIMT, to us that might equate to heterogeneous plaque, plaque that has some soft components, but it's probably mostly stable. And then you have calcified plaque, 64 millimeters. They did provide a stenosis, meaning how much obstruction they have from that same plaque, which is mild, minimal. And they tell you where: proximal, right coronary artery, left main, left arterial descending, and a little bit on the circumflex. So, very interesting stuff. If you see these, this is a kind of the breakdown on the first report, where the plaque is and what type of plaque you will see. So right coronary artery, then left main, then circumflex. No low density. To me, that is no soft plaque, not hot, no hot plaque. Non-calcified, and then calcified plaque. They'll tell you some percentages, and they give you an estimation of, according to their classification, in which stage you will be.
So is low density then non-calcified? That's going to be the soft plaque. Is that what you're saying, Jesus?
Yeah, what I interpreted out of this is low density, non-calcified plaque. And I just saw an article from the Journal of American Cardiology College of Cardiology, where they say that even they acknowledge that low density, non-calcified plaque is an independent risk factor for heart attacks. So to me, this is hot plaque, 100% soft plaque. And non-calcified might be a mixture of both, some soft plaque, some calcified plaque.
So they're saying though that they can pick it up on the Clearly report. They're saying.
I'm not sure. I'm guessing we don't have just yet a report where they are reporting low density non-calcified plaque, but the interpretation, even though this is reported by AI, I think at the end the clinician is the one who makes the choices. And I think Dr. Brewer has an opinion on that and how everybody is going to interpret these results differently.
Okay.
To us,
do.
yeah, to me, if I can, I'm not going to spill the beans. I know Dr. Brewer's position on this. I think the thing is the radiation that's going to be involved. But of course, if you tell me you only can get a CTA, I'll probably choose one report that is more specific and more detailed. Stenosis, meaning obstruction, how much blood flow you will see an issue with. And this is created especially for the mainstream medical community, because this is what they look for, right? They wanna see how big your plaque is. And as we have said multiple times, some cases size doesn't matter that much. I'll be more interested to see low density, non-calcified and non-calcified plaque than just see the grade of stenosis right here. And this is they provide the imaging for each artery. So this is just one example, the left main and left anterior descending, and they put you the measurements that the machine took, how many millimeters from each type of plaque you will see here. And very, very interesting report. And I'll yield to Dr. Brewer so he can give us his take on this.
So I can have another rant?
Sure. I'll put my timer on 20 minutes.
Okay. It won't take that long. Actually, there are 4 points. As you know, I had 3 points before this discussion, and now we've got a fourth. The fourth is lack of clarity and the necessity of the provider to interpret what's the difference between non-calcified and soft, and which one's really dangerous and which one's not. That's a problem too. The 3 other issues that I have actually hold for MRI as well. Someone asked, I think it might have been Black Tengu, asked about, oh yes, Black Tengu said, is MRI just as good as CIMT at detecting plaque, especially hot plaque? So again, MRI, you have some of the same issues in terms of lack of clarity. It's not been classically that good at clarifying very, very small distances. It's not been that good at showing poorly calcified, low calcified areas. So that's really the key question, and CIMT does a little bit better job in that space. I have other issues, which in my mind, I think are bigger. One of them is, 2 of them are not that much bigger. It's bigger for some people, but not so much. So I'll tell you what they are. The first one is radiation. And I don't think radiation is that big of a deal. Yes, CIMT has no ionizing radiation. All of these others do. CT angiogram, especially going into the cath lab, MRI. These others have radiation. In my mind, and in a lot of people's mind, cost is a very big issue. This is very significant cost for these, whereas it's $300 for a CIMT.
I think this is 1,500.
Yeah. Oh, well, thanks. So 1,500. And, if we've heard it once, we've heard it how many dozens of times? Oh, I'm getting the real definitive study. Because you hear people like, I'm blanking on his name. He's the physician that got into rockets. Peter Diamandis, is that right? Talking about how this is the big thing, clearly. And it's not so clear to me that it is the big thing, because number 1, cost, number 2, radiation, number 3, the biggest issue that I have with it is it starts taking you down that plumbing flow sliding board, slippery slope. Once you start looking at, okay, where is the anatomy that's got this blockage? Then you're starting to think about, how can I open that blockage? Stent. Then you start getting into a stent or a bypass based on this plumbing assumption that a stent or a bypass is going to prevent a heart attack. The COURAGE trials, the Orbita studies, both showed that stents don't prevent heart attacks. Then they said the reaction to the COURAGE and Orbita trials was, well, maybe stents won't prevent a heart attack. And guess what? What portion of stents are done to prevent heart attacks? 90%.
90%.
90.
So they don't prevent heart attacks. So that's been proven. Why are we doing more stents than before we proved that? Well, it's financial. Probably financial more than anything else. Too many hospitals, too many cardiology, too many clinics, their mortgage payments are based on getting the putting in stent, getting stress tests and putting in stents. So the reaction after the Orbita and Courage trials was, okay, well, it must be bypass. Maybe bypass is the only thing that's going to prevent a blockage in the artery wall. And sure enough, they did the ischemia trials using bypass. And what did the ischemia trials show?
Bypasses don't prevent heart attacks either.
They don't prevent heart attacks either. And part of that's all based on the assumption of plumbing. And the assumption of plumbing assumes that the arteries in our heart are rigid tubes, like plumbing in the house, copper plumbing. They're not. They're like these new hoses that expand and contract. They're totally different. Dealing with them is totally different from a plumbing issue. So it's a metabolic issue, and that's a major portion of the purpose for this channel, getting that communication out there. Thanks for letting me get on that rant.
Yeah, I'll play the devil's advocate for a moment, Dr. Bruce. One thing that if you're a patient and you're trying to define, I just want to know if I have a high risk, I have a risk for a heart attack or not. What should I do, right? Mm-hmm. So, pun intended, clearly a stress test is not the way to go. So, that's one. Then calcium score, it helps. I think at least at the beginning, it will give you an answer of, do you have plaque, yes or no? And you can find a calcium score pretty easy, and I don't think it's that expensive either. So that's a good option for starters to start. Then you have the 2 or 3 options about, well, I know that I have calcified plaque, I know I have heart disease, but I want to know how close I'm at on the edge, you know. And some people might be we need to talk off the edge even with a positive calcium score. That's another discussion for another moment.
And we do that a lot.
Yeah. But now people understand what a calcium score means, and they know that calcified plaque is not such a big issue if you're doing the right things. But you want to know, okay, how much non-calcified plaque, and better said, not how much soft plaque do I have? If you have a CIMT near you, my personal choice probably will be that one, especially for cardio risk of carotid care, one of those two, which we know have a good quality CIMTs, non-invasive, cheaper, faster, and it will provide us the information that we need regarding soft versus hard plaque. But if you don't have a CIMT near you, and you do have an option to get a clearly report, if I was the patient, because in Mexico we don't have this, but if it was me, I'll probably choose a clear report and will give it a chance. Probably not once every year. That's another advantage from the CIMT. Yeah. You can get a CIMT once every year, non-invasive, safe. A clear report, I don't know if I would like to be on a table and get some stuff injected on me once every year. But if I don't have a CIMT near me, probably I'll choose clearly. So that's just a perspective on how to help you understand and see what choices you might have and what do you want to do to understand your specific situation.
It's a good point. I think I probably would too. If that was the only thing I had available, I'd first prefer a good CIMT, not a bad CIMT, and most of them are bad. Then the second choice, if I couldn't get that, would be a calcium score. Then the third would be CT angiogram. As CT angiogram improves, it might overtake calcium score in terms of second choice. The last thing I would do would be what most people are doing, and that is what you mentioned in the beginning, a stress test.
Sure.
Usually a nuclear one.
Yeah, more radiation. Yeah. So any additional comments before we jump off to the main topic for today?
Not for me. How about you, Jeannie?
Nope, I'm good.
Sounds good. So Gilbert, so I think Gilbert was specifically waiting for us to tell him to jump in to interrupt us with the water ball. I'm just gonna throw that away because it's not the first time, Gilbert. Okay, so let's talk about
It's a
the
good
latest
water
evidence.
ball, and Gilbert does a great job.
Yeah, yeah, yeah.
Despite how much we bounce around.
So latest evidence on dangers of ApoB and LDL. So
Can I jump in and say something?
absolutely.
So I was all excited about that information last week that we heard from Dave Feldman, and Jesus kept scratching his head saying, "Doc, why are you so excited?" And I think his point was we had actually presented some similar information, a few months ago. I had forgotten. But this is still exciting information. It breaks the whole model of high LDL means high risk, high danger, high plaque. This really erodes that assumption. So go ahead. Tell us about your studies here.
So and this is what I was going to start with. These are recycled slides from the show that we have a couple of months back. Of course, we had David Feldman talking to Dr. Brew on the show. You can just Google that. Well, go into the YouTube search and you can see that interview between Dr. Brewer and David Feldman. That was before presenting this. Then he uploaded a video talking about his Citizen Science Foundation and the new study that he was leading with the Lundquist Institute of Biomedical Innovation on the USCLA. And he presented some stuff. So I think he did something like you did on Spilling the Beans a little bit. Because then Dr. Bruce sent me the video from the low carb conference that where he participated. And on that low carb conference, he was like, "Oh, I cannot tell you all the results just yet." But he already did that months ago on a video as well on YouTube, and we presented that. So what he did is he tried to recruit people who were meeting the criteria for lean mass hyperresponders. And if you're not familiar with that definition, this is something that he came up with. He's an engineer. He's not a medical person, but he was dealing with some personal stuff that was specifically that, and he did not find answers on the traditional medical community, as a lot of people have seen that and experienced that. So he reached out to multiple people, to other medical professionals, other engineers, and they saw that he was dealing with a very specific situation. He went on a keto diet. He lost a lot of weight. He felt way better than he was doing that before. His HDL spiked. His triglycerides went down to the bottom, but his LDL rocketed as well. So if you ask any physician, any cardiologist, and you tell them, "Hey, my LDL is 200," they'll tell you you're gonna die. You should be taking 3,000 milligrams of statins right now. And he was not okay with that, as he should. He was like, "Well, if you're telling me that triglyceride and HDL, having low triglycerides, having high HDL is a protective factor, I'm lean, I'm not overweight, I don't have any other significant cardiovascular risk factors other than high LDL. What's wrong with that? Does that really mean that I'm going to have a heart attack?" So that's kind of the summary for lean mass hyperresponder status. So he recruited people like that, people who had been on ketogenic diet for 2 years, people who had LDL of 160 or above, people who saw an increase on that LDL after starting keto diet, people who had high HDL, and people who have low triglyceride levels. Because of funding, he was only able to include 100 people, especially because he had to fly all these people to USCLA to get the testing. So the first time we presented this, and he shared, this is a graphic from him. This is something he put on his YouTube video. When he presented this graphic, I was like, so they're only doing calcium scores? And to me, and I think we discussed that, was like, we're afraid that he might not have all the information and he might be seeing only calcified plaque. Then on the latest show, the latest conference he presented, he talked about non-calcified plaque. So to me, that was kind of a relief, because I was like, well, they are going to see non-calcified plaque, so that's good. At that moment, he had enrolled 64 people, average 53 years old, pre-keto LDL 135, and the mean LDL on keto was 233 milligrams of LDL. That places those people on the top 0.1% of the population. So you might think, if you think, well, this might not apply to all of us, you might want to rethink that again, because by having people whose main risk cardiovascular factor is LDL, you can study the impact of LDL alone with other factors involved. So that's the value of this new research.
Repeat that again, in case somebody wasn't listening. Why are we studying of people that are 1 in 1,000?
Yeah, because a lot of people will have multiple cardiovascular risk factors.
Yes.
You might be overweight. You might be you might have hypertension. You might be a smoker. You might have high triglycerides, which are risk factors themselves. So when you want to do a study about the impact of cardiovascular risk factors, you will have to do a lot of jumping around with the statistics to try to take out the impact of other risk factors on your outcome. But with this population, the only significant risk factors they have is LDL. So this is the unicorn people, as Jeannie called them, the unicorns, where you can study LDL, because this is the only of the main risk factors they have. They don't have all the other risk factors that the general population have. You see that the average BMI is 22. These people are lean.
Mm-hmm.
And they went on keto diet for 4 years. And
it's killing them, right?
Yeah,
that's what the cardiologist thought.
That keto thing is one thing of the devil, and and we're gonna discuss that. There's a very interesting question of a comment from Rick Folia, and Dr. Berg I was telling Jeannie, Dr. Berg posted a video 3 hours ago about that, and we might wanna talk about that on the Q&A about keto and other things related to YouTube. But as you can see here, his baseline information is that from all those 64 people, 85% had no plaque, up to 61% according to this chart right here, right? 0 calcium score. I know this doesn't mean they don't have non-calcified plaque. We're going to talk about that later on. But if you see here, only 2% of those people had a calcium score of 300 or more. And even there, you can say how much of that calcified plaque was built before they went on keto. So at least on the first image, you might say, well, maybe LDL is not such a big issue. Of course, this is just preliminary. This is 64 people. He's going to publish all of this. And he said that as well. I don't want people to take my initial research as bottom line. I want this encourage other people to start investigating and questioning LDL. So what happened with LDL? This is something that he explained that I would like to take a couple of minutes to talk a little bit about that. There was this Dr. Goldstein, I think was his name, about 60 years ago. I think you covered that on the YouTube show as well, Dr. Brewer. Do you remember that case? The case of that young girl with homozygous familial hypercholesterolemia that had a heart attack at age 6.
I have discussed that before, yes.
So this doctor, I believe it was Dr. Goldstein. Uh, he studied this little girl. She didn't have any other significant risk factor other than LDL above 300, and she developed cardiovascular disease, and she had a heart attack at age 6 and died, I believe. Dr. Goldstein then said, well, if this young lady didn't have any other risk factors, LDL is the culprit. It's the only thing that we saw that was elevated. That should be what happened. And that was on 1985, and he won a Nobel Prize on physiology and medicine because of that research. And this research from David Feldman might be the first one to make an opposition to that statement from 1985. Maybe LDL is not that bad, or as he said, might be famous for the wrong reasons.
Yeah, or maybe there's a condition there, a conditional statement that we don't understand yet.
Yeah, the lipid metabolism is not as easy, and I'm putting him. This is a slide from him, but I really like this one because we often don't talk too much about remnant cholesterol, VLDL, ILDL, and LDL, and how that gets, how the metabolism works on that side. So basically, whenever you are eating glucose and even some fat, if you want to see it that way, but mostly glucose, all that glucose gets transformed into triglycerides on the liver, and those triglycerides do not travel freely at the beginning. They get transported on something that we call lipoproteins. And the first one is very low density lipoprotein, VLDL. So if you see that VLDL, and that VLDL is charged with two things, cholesterol and triglycerides. And as this VLDL goes by, dropping cholesterol, dropping triglycerides, the density of that lipoprotein decreases. Increases, and from VLDL becomes intermediate density lipoprotein, and then becomes low density lipoprotein. And you have, if you can see it that way, I don't remember the analogy that David used for this one, but he said you can imagine this like cars that are carrying passengers, if you want to see it that way. And the LDL is boats, yeah, and the LDL is an empty boat, basically. Now you have one, if you see that white thing popping out up there, that's ApoB, and that's just a component. And that remains in a VLDL, IDL, and LDL. So that's why whenever you have a high LDL, you have high ApoB, because they go hand by hand. They're similar on the presentation of what's going on in here. And Dave also posted an article about his lipid metabolism model, and he explained a little bit about how he thinks that triglycerides, once triglycerides are low, LDL empty boats start rising because there's not enough passengers. So LDL is going there. Yeah.
Can I ask a question?
Sure.
On that slide, what are the candy corn guys on the bottom there, the white ones?
Oh, they're ApoB.
The ApoBs, they're not just all blue, like that one ApoB. They have,
and there are other ones. There's ApoA1, and there are other ones. Yeah.
You see the three on the bottom? Is that ApoB still?
I only see one.
Some of that it is. Some of that is other APOs, like ApoA.
Oh, okay.
ApoE, for example.
Okay.
Yeah.
I'm only seeing ApoB on this slide.
Yeah. No, she's talking about the other ones that are not labeled.
On the bottom. They look like candy corn in reverse color.
Look like
teeth.
They look like slide 13. I'm not sure I'm seeing the same thing you're seeing.
Yeah, under VLDL, the first one. VLDL.
Oh, yeah. I see what you're talking about now. Okay.
Yeah, you see what I'm talking about? They do look like teeth. So that's not ApoB though. What is that?
No, I believe it's ApoA1, ApoE, other particles like that.
Yeah, there are other proteins that are involved with this, but it gets back to a very old video I made. I took a bottle of water and I put some olive oil in it, and I basically, used it as a visual to show that what do we do when we eat, even if we're saying, okay, I eat a low fat meal, but then you use something like olive oil dressing. Olive oil dressing in that water, or olive oil in that water, forms a big blob. And that big blob can and will cause heart attack, stroke, all of these things, because it forms what we call a fat embolus. Our body forms proteins which will not allow these oils and fats to form a big blob. And that is exactly what ApoB is. ApoB forms VLDL, IDL, and LDL. ApoA1 forms HDL. And the DL is density lipoprotein. And that's originally how these were characterized. We knew that they floated at different levels. And the HDL floated the least because it had the most protein and the least fat associated with it. So when you begin to understand all of that, it begins to become a lot clearer in terms of what's going on. It's also related to what Jesus brought up, that the VLDL is really an LDL with extra triglycerides in it. And it's unfortunate that in this slide, it doesn't show the triglycerides splitting off. Most people think of, oh, well, an LDL particle is something that's been there for days or weeks. No, just hours ago, after the most recent meal, the olive oil, the other fats that were carried, and as Jesus pointed out, if there was a lot of sugar or carbs ingested, the liver's making triglycerides as well. All of those are being piled up onto the LDL particle, and that's creating a VLDL. The VLDL is then taking that out to muscles and other areas where that fat can be used, mostly to fat deposits. So,
and Bill Kearney is helping us right here. ApoC, yes, I forgot about ApoC. That's right there as well.
Thank you, Bill Courtney.
So glycoproteins. Yeah. Good. So this is kind of the stuff, and all these people that we're talking about in the LMHR, lean mass hyperresponders, they will have a lot of this, a lot of high LDL.
Because they're basic in Dave's mind, and in most of the minds of those of us who are dealing with this, basically what's going on is they're not eating a lot of carbs, so they're having to transport their meals, the fats that they're getting with their meals, they're having to transport it with LDL. And so that's why he's saying, yeah, you got a whole lot of empty boats lying around. It's those LDLs that are being used to transport those fats.
So we take that out of the way. That's kind of the geeky part of the show. We love to be a little bit geeky, and we have people that are really telling us, hey, you should not be doing that if you want to grow your audience. But still, we have a lot of audience that, as you saw on Bill Kearney, for example, there are people who are aware of how this works. And we're trying to share to the people who are not aware as well, so they can understand a little bit more about that aspect. So if you go to the baseline info, you will see here, they included 100 people. 100 people were on BMI below 25. And the average keto, people on keto diet, I believe was around 4 years. And 60% were male, 40% were female, which is a really good ratio for people who are on to have a kind of similar population between male and female. If you see here, they did have a couple of people who had some extra risk factors. So it's not as clean as we would love to see it, but it's not as the general population either. So 31% had some family history. And I think that's lower because a lot of people, general population, might be around 90% of family history.
Hmm.
Other family members who had a cardiac event. Past smoking, 3%. Hypertension, 2%. That's 2 out of 100. And chest pain, 1 out of 100. And this is the lab work, the baseline information from the lab results they had. So the mean total cholesterol was 360. The mean LDL was 260, basically. But if you see here, the main HDL cholesterol was 88, and the mean triglycerides was 69. So if you go ahead and do the the triglyceride of HDL ratio, that's near 1, way below 2, which is the risk factor. And he included this information. Where he taking that? This is the 0.1%. He is taking that from the enhanced sample of LDL. So only 53 out of almost 50,000 people had an LDL around 260 or more. That's 0.1% of the population.
So let me repeat and clarify something. This is not his current data. This is data that he presented on our channel 6 months ago, 8
This
months.
this is the current.
Oh, this is the current. I'm sorry.
This is the current because his total sample is 100.
Okay.
The things that he presented the last time was when he had 64 people.
64. Okay.
So
Thanks
this is the
for the
100, and
clarification.
this is what he's gonna publish.
Okay.
And he's thinking about doing more research on this side, and he's now trying to get 100 more people for controlled and another more 100 people for we did not match this one strict criteria that were not exactly on the 4 years of keto and other stuff. So he's trying
Mhm.
to expand on the research. And this is something that it's pretty interesting if you can see it here. So he said, you know what? There's a couple of ways that this thing could go. And he wanted to have a kind of a perspective. What will happen with this preliminary information? Because of course there is some ethics that need to be enforced. And
Mhm.
I realized that he was indeed looking for soft plaque, not only calcified plaque. So he said the first scenario that we might have is if people are we scan them for the first time, which he already did. He already completed the CTAs for the 100 people. If we see that we have a lot of people who have non-calcified plaque that they are on a very high risk, we might not want to continue the study. Non-calcified plaque means higher risk factors, and they might need medical assessment, and he doesn't want to be personal responsible of saying, hey, you're okay, and then the evidence saying you have a lot of non-calcified plaque. So that was kind of the first scenario, and he will stop the study early. The scenario number 2, proportion of the patient were on a medium to high risk. So he was going to assess if the study should be continued. And you can see that on the graph. The green light is still lower than the orange and red proportion. Scenario number 3, they had a lot of people with non-calcified plaque and some people with non-calcified plaque. So the study could continue and looking for a more long-term proportion, probably to study for more time. The fourth scenario that he had until that moment, this is the fourth scenario presented, or was this 4 scenarios where when he didn't know the preliminary results just yet. So scenario number 4, he will have a lot of people who were on the low risk category, just a few people with non-calcified plaque. But then he kind of spilled the beans a little bit on saying, well, when I saw the preliminary results, I realized that I didn't have a 5th scenario. And the 5th scenario is I had no people with non-calcified plaque. So from 100 people, he didn't thought, even he didn't thought that 100 people will have 0 non-calcified plaque. So this is people on keto diet, very high LDL above 200. And he's kind of saying, none of our people in our population had non-calcified plaque. So they were all basically, if they had plaque, it was calcified. Do you want to translate what I just said, Dr. Brewer? Probably you can help me
Uh,
do that.
you're giving yourself a hard time, and you often have to translate for me as well. Basically, I think what you're saying is you're asking the question: Did Dave imply spilling the beans by saying not only did it not increase the risk, did it dramatically decrease the risk? Did these people have significant decrease in risk for soft plaque?
And it
Is
will
that
be
what
interesting
you're
to
saying?
see. Yeah, and it will be interesting to see. In order to say that they had a decrease, we might need to have a baseline. If they had a calcium score of a CTA before to compare,
Yeah.
probably not all of them had from where they before they started keto. Probably a lot of them had, because sometimes you start keto after realizing that you have plaque,
So,
but at least, yeah,
go ahead.
but at least here he's presenting stuff, and he said my results are very similar to something that was presented before. Calcium score prevalence in his population is near here, where on this this is a study of keto people who did keto, and almost 60% of them had a calcium score of 0. So his population is near here. Of course, this keto study didn't measure non-calcified plaque, but he's saying probably 100% of my population, 100 people, we know some of them had calcified plaque from the previous report, but probably 100 of them do not have soft plaque, or they do not have non-calcified plaque, which is the one that concerns the most, at least to us. We're not as concerned as about calcified plaque as we are about non-calcified soft plaque.
Okay, so Jesus, let me see if I understand this. What is being said is that if the unicorns with the high LDLs in the 260s, right?
Yeah.
That if that group,
After 4 years of keto,
after 4 years of keto, even though they're up that high, they do not have soft plaque. Because they're the lean mass hyper responders.
Just said it way better than I said it. Yeah.
I have to dumb it down because
I needed
you guys are up high.
For that. Yeah.
Got to bring it.
No, we're just not good communicators. That's what's going on.
Yeah,
and we're also trying to dance around our wording.
It's okay. No, it's actually that you're smarter. So I'm bringing it back to the people.
No.
So, because I'm the people. But what I would like to say is, so what you're saying though is LDLs on a lean mass hyper responder it isn't a true picture of actually what's going on, and beating down their LDLs isn't going to decrease the risk of anything because they don't really have soft plaque. Is that what we're saying?
Exactly right. And this can translate to the general population on the side of, if you have multiple risk factors and you are too concerned about taking 40 milligrams of Lipitor to decrease your LDL, and you think that's going to save your life, and a lot of doctors think that might be the case, you might want to put the same efforts to take care of the other risk factors: losing weight, controlling your blood sugar, controlling your insulin resistance, controlling your blood pressure, controlling other stressful factors outside of that. So all that other stuff plays a role as well. Probably a bigger risk factor than LDL and even ApoB, because they're tied together.
Okay, and then one other question on that. If let's say that,
could I ask?
Sure.
So, Jesus, you brought up a good point. The danger is not in taking the increased statin. There's some danger. A lot of people are very afraid of statins, but not some. We're not. The danger is thinking that the statin is going to fix the problem when you lower your LDL. Yeah. Meanwhile, your triglycerides are up there, your HDL is low, and you're not dealing with the metabolic issues that you need to deal with.
Yeah, you're too concerned about LDL not depositing on your inner layer of your coronary arteries, but still you have a fire right there with cardiovascular inflammation.
Another point was, I've had lean mass hyperresponders that were very concerned about this LDL level, and to their request. I put them on statins for it, and we've actually even gone to PCSK9s, and they were happy to do that. My perspective was, I think you're a lean mass hyperresponder. I don't think LDL is creating this kind of risk for you, but the patient knew the evidence and just wanted to have suspenders and a belt. And so I think that's reasonable and will be reasonable until all of the evidence is in on this issue.
And we have considered that, of course, when you see a blood sample of somebody who has a total cholesterol of 500 of an LDL cholesterol of 300, you start to be concerned also about the fluidity of that blood. When it's mostly fat, of course that's going to impact in some source.
Viscosity.
The viscosity, yeah.
So, Jeannie, thank you for letting me jump in there real quick.
Sure. No worries. It is your show, of course, but
I totally get you, Jeannie. I'm dealing with this for a couple of months now.
You guys sound like I'm a tyrant or something.
Dr. Brewer likes to rule with an iron fist, so that's just the way it is. We peasants. I'm grateful. It took me months to be able to talk a little bit more. Until now.
Well, he lets us say little things here and there. But the thing that I was saying that I probably have forgotten what I was trying to get to. I know what it was. So I had gotten an email from a patient recently, and he had been on high dose of statins. He had been, we switched him over to rosuvastatin, changed his diet, did a lot of things. I think he was thinking heavily because the email came in after midnight, but he was asking, hey, he's on 5 milligrams of rosuvastatin. Wouldn't it be better for him to go on 10? Dr. Brewer, what do you usually say to that?
I think I know the case that you're talking about. And my first response was, again, you're the executive and what you're asking for is not unreasonable. It's clearly within a lot of standards of medicine. I don't, it's like the case that Jesus brought up where somebody has really high numbers and they want to continue to beat that LDL down. Yes, we can and will do that as long as it's, it's something reasonable. And the patient understands what we know about the relative risk.
And so it won't necessarily change anything because the 5 milligrams is shown to be just as effective. So, right. So,
the 10 milligrams is likely to be more effective at pounding down that LDL.
Mm-hmm.
And that's what that patient's doing. That patient's saying, like some of them do, yep, I'm familiar with this lean mass hyperresponder thing, but I don't entirely trust it yet. I want to have suspenders and a belt to hold my pants up. And so, yes, I'm going to work on my lifestyle, but I would like to get that LDL lower. And I'm totally comfortable doing that.
Okay, and just kind of as an extra backup because they're used to the 40 milligrams. The 5 seems too low. In their head, 10 is better.
Correct.
And if you ask me, I think suspenders work better than a belt.
Well,
that was not the discussion, right?
Well, maybe it was for you. Maybe that's what you got out of this.
No,
we have been getting. I'm going to digress further. We got some feedback about the banter that goes on here and laughter, and most folks have said this is great. It's far easier to listen to. Because what happens when you have a long one of these is like the Wednesday show, is you tend to plug it in and you go do your gardening or whatever. And when there's an image, you pull your phone out and you look at the image real quick. It's easier to listen to people talk than it is to listen to somebody just droning on and on and on. One person recently said, I wish y'all talk less and answer more questions. And so you know where that's going. That's going back at the answer Nazi. The bottom line is, yes, we cut up about that too. We do want to we're not quite there yet, are we?
I don't think so. I think we can do better. I'm just going to say that we should bring back suspenders.
I see what you're saying. So
he's saying right now, Jesus, he's saying right now, are we at the answer Nazi time?
Oh
Yeah.
yeah, I think so. I
And
think the bottom line just Jeannie did the bottom line like 5 minutes ago.
yes, and that is, it's not critical. And given what we're finding out about low carb and its impact on LDL, it doesn't appear that that kind of LDL is really conferring a lot of risk, when you look at evidence like this. But we also agree that it's very reasonable. That's the standing model right now. And LDL does matter in some cases, I still believe.
Yeah.
So if a patient wants to continue to pound that down, then yes, we can. The point that I was trying to make, though, is that our goal is to make the best. Our goal. Let me switch now to talking about the banter, the laughter, the YouTube show itself. You'll see us continue to do work on the YouTube show. You'll see us experiment with a little bit more banter, with having multiple people on like we're doing now, because the goal is to provide information. When we have a new patient come in, more times than not, they tell me, "Oh, you already helped us. You already helped me save my life. I've lost 35 pounds. I know that gave me another decade of healthy lifespan." So we know we can and will continue to save more lives with the videos. They're not a significant income for us, although, well, I have to say that actually some of the super chats, all those things do help in terms of our model. Our goal is not quite so much to make income from this channel. Our goal is to help save lives. So we're going to continue to do the best we can in terms of providing the best experience for folks so they
Also,
learn this information.
we would love to get income to save more lives, of course.
Absolutely.
So join the channel, hit us with a super chat, or just interact with us. That helps.
There you go.
Share the video, click the like button, send it to both enemies and frenemies and everybody.
There you go. Now, I sort of transitioned without giving all of us a chance to recap and end up the lean mass hyperresponder story, the LDL at 260. Anything else on that before we go to the Q&A?
I'll say two things. So interpretation is critical, just like with the Clearly report. A Clearly report will have two different consequences depending on who sees that. If Dr. Brewer sees that, we'll tell you, okay, you have soft, non-calcified plaque, you will need to do this and do that. I recommend you to consider this and that. Because probably Dr. Brewer will not tell you what to do. We'll tell you, of course. And if you share this with your cardiologist, he will likely, even with just some non-calcified plaque, he would like to put you on a stand even if you are not having any symptoms or cardiac arrest or heart attack at the moment. So consider that. And with the LDL, it's the same thing. Some people will see this and probably will say, well, but this is people, these are unicorns. This doesn't apply to the general population. Or some people will say, hey, probably we might question our paradigms and start putting more emphasis on other risk factors and not just LDL.
These are metabolically healthy people. Now, I'm glad we went back to the Jeannie. Anything before my last comment on this?
No, I think I'm good. Thank you.
So actually, I'm glad we went back because I have a question for you, Jesus.
Oh,
you mentioned CTA, or what's that?
I'm concerned now.
Uh-oh. So you mentioned, how did they find soft plaque? You mentioned CTA. They didn't use CIMT, correct?
No, they did not use CIMT. They did use CTA angiogram. Yeah.
So I just got through saying that I prefer CIMT to CTA, and here we've got a research group using CTA. Any comments or thoughts about that?
I think that what they are going to miss is, of course, it seems that they did not find any non-calcified plaque. But with a CTA and a standard CTA, they are very likely to find non-calcified heterogeneous plaque, which is mostly stable. They'll still probably miss soft, hot plaque. That's
interesting.
One of the main concerns.
So it's actually probably there, but it's not going to pick it up. because
It,
we
it, the standard,
really haven't seen.
the standard
You think
CTA is
so?
interpreted by physicians, or they're usually radiology experts. But I don't know.
But
Probably
but
David Feldman has an expert on his side, and he's providing CTAs that have a report on soft hot plaque.
So he's you remember, I think he's doing this with Matthew Budoff, and we've
Yeah.
reported, we've talked with him, we've reported on him a couple of times. He did a lot of the basic work on calcium score. And when I talked with Dave, yes, they had some pretty good guys reading the CTA. I'm not so sure that they're going to be missing a whole lot of hot plaque. I will say this, though, CTA is becoming the standard for a lot of academic centers. It's becoming the standard for a lot of folks. And that's why we keep hearing about, well, let me get a CTA, especially the AI-driven CTA. It doesn't mean that I think it's the absolute best for the reasons that we discussed. Like I said, as Jesus brought up, there's a lot of problems in terms of interpretation once you get to the end and you get that CTA report. Number two, radiation. Number three, cost. And number four, it starts taking you down that anatomy, flow, study, plumbing assumption to where you're headed for a stent. So that's my wrap up on this information that we presented earlier today. And I do think if you'll give us the transition, Gilbert, we'll go into Q&A.
So, Gilbert, can you show us that image
Where's your,
that we
where's
are
your
so
picture?
proud of?
Uh-oh, here we go.
Yeah, that's the
So
one.
there he goes. He's still being the answer Nazi. And as you'll see, I'm sort of slipping around behind him sometimes, getting answers out when I can.
I'm gonna turn in some type of Gestapo for questions, right? So no, this is just advertisement. We're just playing around. But the main thing is, if you want to get your answer first than everybody else, I suggest you to become a YouTube member. If you're subscribed, of course, that helps a lot. We appreciate that. We're just trying to bring some order to the way we answer questions. So become a YouTube member. The Gilbert can show you right there how to do it. Just click on the join button, click the notifications bell, hit the like, share the content. By joining, you will get an icon right here next to your name, just like Black Tengu. And that way I'm able to identify which questions we're going to address first. Sometimes this becomes a one person asking everything show. But that's the thing. That's the perk of becoming a YouTube member. So Black Tengu says, is MRI just as good as CIMT at detecting plaque, especially hot plaque? And I think we already addressed that real shortly. The short answer is no. That's the short answer.
And I gave him a written answer too.
Oh, that's the one but you don't need to do that behind my back for YouTube members. I'm gonna answer them anyway. You should do that for people who don't have the icon.
Here we go. Okay. So I didn't realize it. Didn't think through it, did I?
Go ahead.
No.
These are your words.
So the MRI it's got some of the same issues that CTA does, especially, getting a very small delineation. We're talking about a human hair here for plaque. That's how big we're talking about. We're not talking about something as thick as our finger. The second thing is MRIs always had a little bit of challenge in terms of the technology picking up gradations of calcification, which is a big deal here for what we're talking about. And then again, it gets to the other three issues that I had with CTA: cost, radiation, and taking us down that slippery slope towards getting a stent.
Yep. Good. Rick Folia says, good morning from Atlanta. Rick Folia is avid follower. We appreciate. He has even sent us an emails and proposing some topics that we have covered, so we appreciate that. And this is what I was going to tell you about, Dr. Brewer. I wasn't aware of this. Thoughts on YouTube censoring all medical advice not aligned with the WHO, AHA, etc., especially if the video contains the word keto. Try searching for keto on YouTube, only get how bad it is now. Really interesting stuff. I saw an article from The Hill where they say that stuff like garlic cures cancer, take vitamin C instead of radiation therapy will be removed. To me, that makes sense whenever the title is proposing to do some alternative treatment instead of a life-saving procedure or treatment. But if they are just putting keto and everything is said keto is so bad, that's a concern, especially right to us that we're trying to improve a title process on their YouTube videos. I'm dropping a bomb on you right here, I think.
Well, yeah, I'm still skeptical as well. I can, MD Anderson Cancer Center in Texas, right?
Mm-hmm.
And what's the other one in New York?
We talked about this last time. Forgot it.
These cancer centers use keto in the treatment of cancer. Are you telling me that YouTube is going to get to the point to where they outlaw the term keto?
I think it's just taking it out from the algorithm. And
well, yeah. So I'm still a little bit skeptical about them being able to say anything keto is going to be outlawed, or low carb. I mean, it's like, I realize there's way too much non-scientific information being spouted about all diets. If they do that, then they're going to need to put, what is it called? Shadow fake or something.
Yeah, I know who you're talking about. Yeah.
Silent, whatever. But train the AIs to not show that stuff.
It's shadow ban.
Because then they're going to have to do that with, what's that?
Shadow ban.
Yeah, shadow ban. That's right. So
and Sloan Kettering. Sloan Kettering was the other thing.
Yeah, Sloan Kettering. I mean, all these cancer centers use keto. It's not the cure for cancer, obviously, but it does help with a lot of different cancers. And to say that they're going to shadow ban that, weirder things have happened. And when we get into that kind of dystopian world, we'll deal with it at that point. The world's getting more dystopian, but you know what? I'm going to go down fighting.
Amen, Dr. Burr.
We're really very, very benign, very benign. Everything we talk about is, that's the whole point to this channel. It's very much science, evidence based. We did apply, there's a YouTube thing now that under some doctors' YouTubes, you'll see it as presented by a doctor certified or licensed in the US. We applied for that a couple of weeks ago. I don't know how many weeks it takes for that to show up, but as we all know, I'm licensed in all 50 states, current and active. So we should be able to get that at least sooner or later. And thanks for the warning, Rick, but we got to do what we got to do.
Dr. Burr's Army.
There you go.
That's for anybody who likes Harry Potter. So you're kind of a Dumbledore right here.
Oh, is that what it is?
I didn't get that.
Just like that, Dr. Bruce said, I never seen Harry Potter movies.
No, I have. I loved them.
Okay.
I've actually never seen them.
Oh, they're really good. And a lot of people tell, the books are better. Probably they are. I don't know. Okay, Black Tengu. Dr. Brewer, some time ago you stated that eating lentils raise your blood sugar. Normally in Greece, we eat lentils doused in extra virgin olive oil and maybe a big slab of feta cheese. So 2 things right there. I wasn't aware Black Tengu is on Greece.
It's in Greece.
So
I wasn't either.
I wouldn't either.
He never told us.
No, share with us. Where are you from?
I thought he
We
was
have a
in
lot of people
Japan.
from the U.S. Yeah. And if you're a YouTube
That's a
member,
good
I'll just
point.
see your
Maybe
comment.
go ahead.
No, go ahead. Go ahead.
Anyhow, I already responded to that one in writing somewhere. But the bottom line is that's going to improve the glycemic load.
That's the same thing that I thought. He's
And
using olive oil and feta to decrease the glycemic index of lentils.
one of
Yeah.
our staff members really gets mad at me because I keep talking about low carb, and she does work elsewhere as the vegan doc, and she and I tend to go round and around. But the reality is, I tend to eat, and have most of my life tended to eat mostly plant-based stuff. I shy away from meat less than I used to. For about 25, 30 years, I ate less meat. Now I eat a little bit more. Now I'm going back again less, just because the people I'm hanging around with don't eat a lot of it. Bottom line is, her question and concern was this thing about carbs. And it is true. Fiber is a carb. FDA says fiber is a carb. So one of the videos we just did about oatmeal was, a sugar's not a sugar, is not a sugar. You know, oatmeal is really a sugar. That's the problem with it. And guess what? Fiber is not. It's not a sugar. It's a carb, but it's not a sugar. So yes, we also talk a lot about eating to the glucometer. And here's the problem that Black Tango brought up. It's about half and half. Some people, when they eat lentils, their blood sugar will shoot up. Others will not have a problem. And again, it's in that, more in that legume space. Some nuts are highly unpredictable in terms of what kind of glycemic response people will have. Glycemic means glucose in the blood. Glycose is glucose, and emic in the blood. So again, maybe I've confused the heck out of the situation, but eat to the glucometer. And yes, adding cheese like feta and olive oil is going to greatly slow down. If you have any if you're one of those 50% of people that have problems with lentils, adding these two things, these two fats, will slow that down a lot. So I took 5 minutes to give a 30-second answer. I'm trying
I think if I can give my 2 cents right here, we also have found that being totalitarian about stuff, Dr. Brewer, being totalitarian sometimes doesn't work. There are people who eat like near zero carbs and they have struggles. So sometimes carbs are necessary. I don't think we are condemning carbs and saying do not eat any.
No.
But of course, we know that when you're eating them excessively, or you're not aware of which carbs spike your blood glucose and insulin, that's when you have a problem. And it's a lot about self-acknowledgement and understanding what works for us, because not everything works the same for every person. It's a lot of experimenting with diet.
Well, and we had a lot of discussion about this yesterday. And but one of the things that the vegan doctor talks about too, when she talks about eating carbs, she's not talking about little Debbie's. She's talking about a sweet potato, you know. So it's a, you know, a grown organic type of carbohydrate with fiber in it. And we're going to talk more about that, the whole how to figure the glycemic index, and how certain foods with a lot of fiber as part of the carbohydrate it's a different there's a ratio, and if it's less than 5, then it's like in the safe zone. So we're going to try to cover that more, because we know this is a confusing topic. Even when we're describing it to people, we have some work to be done in that arena, I would say.
And we're gonna have her on the show as soon as she's ready.
Yep.
Good. So Rick Folia, can CA be done if you have stand? I think he's talking about a CTA. Yes, the short answer is yes. Do you have a long answer for that, Dr. Brewer?
No, I don't.
CTA be done with the stents on? The answer is
I
yes.
don't.
MRIs have radiation. I thought they didn't. You're right, Rick Folia. MRIs don't have
Yes.
radiation.
I
I
said
think
that before, and that was a mistake. Thank you for pointing that out, Rick.
I think you meant CT
I was
CT scans, right?
yeah,
Yeah, CT scans
conflating that with
do have radiation. MRIs don't have
ETA.
radiation.
Right.
But I even in the for the purposes of identifying plaque, I'll choose a CTA even with their radiation rather than an MRI. I know an MRI might be safer on that space, but it's not going to give me the information that I need.
At the end of the day, people that worry about radiation from these studies, I mean, they're on the order of 1% when if you get them if you're an infant in terms of mortality risk, and the stuff that we're talking about, cardiovascular disease, is on the order of 8 to 10% per year as an adult. I mean, that's what we're trying to rule out. So they're in totally different orders of magnitude. It's not worth worrying about the radiation.
Yeah, exactly. Unless you are a radiology technician, then you are worried about radiation. You're exposed to that every day, right? Ruben Morawiki, those depleting your glycogen reserves, for instance, by exercising vigorously, increase your glucose uptake by cells? Really interesting question, Dr. Brewer. Do you have any opinion of that?
Say that again. Does depleting your glycogen reserves by exercising vigorously increase your glucose uptake by cells? Well, we know that exercising vigorously increases glucose uptake by cells. That's exactly the whole point. That's why we talk about increasing your muscle metabolism. And that's why we talk about loss of muscle mass past age 65 is such a major risk factor. Now, so I think the answer to the question might be a little bit overly self-evident. I'm not sure. You think I'm misinterpreting something on the question?
I think the bottom line is I agree with you. I don't think that the reason is by depleting glycogen reserves. Depleting glycogen reserves means all that packed glucose that you have on your liver and some in muscles is going to go into the bloodstream and it's going to be allowed to be used. So in a sense, by depleting your glycogen reserves, you're allowing your muscles to grab that glucose right away. So that's just a normal mechanical process that happens, metabolic process that happens. That's good. On the muscles, yes. On the rest of the cells, by depleting your glycogen reserves, again, it depends on your overall glucose metabolism. If your muscle is using that glucose, yes, that's going to probably bypass most of insulin receptors. But that's a process that you have to train your body into. So it's not the same to deplete your glycogen reserves by exercising than doing that by, for example, just fasting. Yeah. I think the process is different. Fasting helps with other mechanisms, but it's not just about depleting your glycogen reserves. I don't know if that's kind of clear.
So will it be that the muscles use?
Go ahead.
Will it be that the muscles use the stores as opposed to just having no caloric intake, and so it's pulled out of the system? I don't know. Does that make sense at all?
You have glycogen reserves both on the liver and muscles.
Mm-hmm.
The ones on the muscles are going to be used automatically, immediately. They're right there. The ones on the liver have to go to the bloodstream, and then they can be used in other places. So it depends.
The reality on depleting glycogen reserves is I think you're pointing out, it takes 3 days routinely to do that, depending on where you are. Now, if you start fasting from a depleted state and you do a lot of exercise during the fasting, you're gonna get there quicker.
Yeah. Yeah.
The other point that you made was there's a metabolic issue here. It's not just a glycogen depletion.
Exactly.
And what that's doing is stimulating autophagy, which is a big deal.
What Jesus tried to say, and then Good.
So what Jesus is trying to say is, let me ask you this, because again, it's just one of them deep suckers. If the glycogen, so potentially the glycogen from the liver would be used with fasting, and the glycogen in the muscles would be used with exercise. Could we say it that way? Or
Yeah, I'll say that. Yeah, you cannot use glucose from glycogen on the muscles if you're not exercising.
Would you agree, Dr. Brewer?
You cannot use glucose from the muscles if you're not exercising. I would agree with that. Yeah. It's not going to come back out.
Right.
Yeah.
Okay.
Bill Courtney. So the conundrum is that the carotid and coronary are two different vascular beds. I have a good CIMT, according to my age, but I have a high calcium score. Shouldn't this disqualify CIMT for coronary health? Really interesting question from Bill Courtney. Do you have any perspective, Dr. Brewer?
Why don't you go first? You're both.
And sometimes we do that. Dr. Brewer needs to analyze the question so he can provide the right answer. So after I miss, he comes back and makes the same.
I know the answer to this one.
No, but I can understand. When Dr. Brewer introduced me to CIMT, I had this same concern. And I started researching a little bit about that. So it depends to you. What's the purpose of you getting a CIMT? Or what's the purpose of you doing that test? If you say a good CIMT according to my age, I'm concerned of understanding. Did the CIMT show plaque? Yes or no?
Mm-hmm.
Because if you're leaning on to see the arterial age, probably that might mislead. And probably we have different definitions from a good CIMT, right? If it is from cardio risk, I probably will agree if they say they do not have plaque. Now, just say I have a high calcium score that should be catched up by the CIMT. My perspective is probably there is a small proportion of people who will have plaque only on the LAD, on the left arterial descending artery. That's the more common one. And they don't have any more plaque on other coronary arteries. And it's probable that they might not have significant plaque on the carotids. I can agree with that. My personal perspective is to have a high calcium score at the beginning and then CIMT as follow-up. That's my personal perspective, of course. But I think most people, about 90% of people who have plaque on the CIMT, who have a calcium score, positive calcium score, will have plaque on the CIMT. So I don't know if that's a miss, Dr. Brewer.
No, I think you bring up some good points. Jeannie, were you getting ready to say something?
Well, I was going to say that my reading into this question is that you have a good CIMT for age, which, you know, that's something they put in there. And that's, I think, something that maybe you can watch with time. We don't always say that's completely accurate, but that's a piece of information that you get. But I have a high calcium score. Should this disqualify the CIMT? Not really, because the CIMT gives us what type of plaque it is. Is it calcified? Is it soft? And then we can watch the progression from year to year with that. If you would then repeat your calcium score, it would probably be higher as you do better, because the calcified plaque would be there. So we don't necessarily recommend repeating the calcium scores all the time, but the CIMT is another piece of data that we can kind of assess yearly, and we can determine if you're having soft plaque or hard plaque. Have I learned well?
You bring a really good point. The high calcium score doesn't necessarily mean that there's soft plaque, and the CIMT can tell you that.
Yeah, I agree with it. You guys both have had good points. And I think, Jesus, you're the one that brought up, you need to think about age. So for example, your typical 60-year-old is going to have some plaque. That doesn't mean that a CIMT, that we're not going to get good news out of a CIMT. What we're concerned about is soft plaque. We're not concerned about calcification. And in fact, if you're like most of our patients, and you weren't always the most pristine with your lifestyle, in fact, maybe you lost 35 pounds 2 years ago, you're very likely to have a high calcium score. And, depending on what you're doing with your lifestyle now, no soft plaque. We've talked about that multiple times. I'm not. I'm trying to understand the assumptions that you're bringing to the table, Bill. It would be helpful to know the age that we're talking about. It'd be helpful to understand what you're looking for. Another thing, when you look at the actual numbers, we already know that 2% of people that have plaque here don't have it here, and vice versa. So again, we're not. Our goal is not to tell you whether you have calcified plaque in your coronary arteries. It reminds me of that scene in The Fugitive where Harrison Ford held the gun on Tommy Lee Jones and he said, "I didn't do it." Tommy Lee Jones's response, he's got the gun on him, was, "I don't care." And it surprised the heck out of everybody. And I'm sure it would surprise the heck out of Bill if I said, you shouldn't care if you've got calcium in the arteries of your heart. That's not what's going to tell you whether or not you have significant risk for plaque. Does that help?
Helps.
It does. It does. Good. So how much time do you have? We have a couple of other members asking questions, like Rick Folia.
Yeah, let's go ahead and finish those out. I need a few minutes before my 12 noon visit.
So let's speed it up. Rick Folia, those is asking answering to just Rusty about those traveling shows are not CMTs. It's an ultrasound flow study. So you will see a lot of that. And I think I'm gonna jump on one question that I saw from Peggy Douglas saying, check with the PrepMed and CMT company recommended. Disappointed that there's no access to CMT within 4 hours, so I agreed to bilateral carotid ultrasound. Am I wasting my time? For our purposes, probably yes. I haven't seen a carotid ultrasound report that characterizes plaque. They sometimes tell you there is plaque and there is blockage, but that's it.
Yes, it is wasting time. Basically, what that test is telling you, it's a flow study. It's not looking at the actual amount of plaque and clearly not looking to see if it's soft or stable. And the outcome of that study will say, do you need a carotid artery surgery or not? And that's just, the carotid artery surgery story is worth resurrecting for a second. I trained with a fellow named Louis B., and I won't use his last name. He was the guy. This was in Charleston, South Carolina, almost 40 years ago, and he was doing more carotid endarterectomies than anybody in the whole region. He was the carotid endarterectomy guy. Now, let me ask you something. How often do you see carotid endarterectomies now?
I don't see. I don't think I have ever seen one.
You don't. And when I was growing up in medicine, there were guys like Louis B. who were just wailing away on them, and they thought they were saving the world. Why are they not doing those anymore?
Probably didn't do any good.
Because it became really clear that they were not preventing strokes. But yet, and so we were doing that to improve the flow of the artery to the brain. And guess what? We're still doing stents and bypasses to improve the flow of the artery to the heart. So no, I wouldn't get a carotid ultrasound. What you want is a CIMT.
Bill Kearney, I'm not afraid of statins, but what's the problem? My cardiologist want me on the statins without finding the problem. I want to find and fix the problem. So your cardiologist probably is thinking that LDL is the problem.
That's where most of them are going.
His search is done. He found high LDL. That's the problem. Here's the solution. See you in 1 year. Yeah. Or when you have a heart attack. Whatever happens. Yeah. So, and I have a couple of, I have patients in Mexico who said, I got a CTA, but even though I had some non-calcified plaque, my blockage was like 25%. And the cardiologist told me, come back when you have 75% of blockage. Well, at least he didn't get a stance right away, but they get like the general advice of eat better, do exercise, and that's partially correct. I mean, they're right. You need to exercise and eat better, but they don't give you more details about how do you do that. And some places even have thanatologists, psychologists specialized on grief, or it's grief. That's the word. Because changing your lifestyle from being on carb vacations all the time to switching to a more healthy eating and exercise, it's hard. You're losing something. You're doing something different that you used to do, the way you used to do it. David Bacon, very useful info, digesting and explaining Feldman's LMHS data and efforts. That's what we try to do. Bill Kearney, if I eat more saturated fatty acids, it raises HDL. Is that good? Is that good,
Yes.
Dr. Burr?
Yes. That's good.
I would agree with Jeannie. Increased HDL is a good thing.
Yeah,
Good.
I don't know anybody that's going to argue with that. Now, a whole bunch of people are going to argue with eating the saturated fat. But
and another stuff.
It's another bunny hole.
Yeah, and other than diet, also niacin helps on raising HDL. And you might be aware of this. And my personal experience or perspective is I'm a little bit more laxed on some medications like ezetimibe. And I wanted to tell you that and cover that because I've seen a couple of studies where it says that ezetimibe might decrease inflammation a little bit, and it does have an impact on HDL. I don't think it's really big, but some people might benefit of that. I don't think
they might, and I don't think I'd ever say never use ezetimibe. I just don't use it a lot for reasons we've discussed.
Yeah. Without finding the problem.
Into polypharmacy, and most folks are trying to pound down the LDL.
Yeah, I agree with that. David Bacon, what specifically should we put in front of our cardiologist? It is a few weeks away. I don't know if there's something that is gonna work. People have taken Dr. Burr's book, have taken evidence onto them. What do you call? What did they say about OGTT testing? These tests are rigged to fail.
Rigged to fail, and I don't think I would take him a big printout of the articles that we quote. They're not going to read it. They're too busy.
Yeah. So good luck with that. Bottom line is, I don't think there's something that you can take your cardiologist that's going to open their eyes, unless your cardiologist is open for that.
Yeah, more and more folks are headed that direction. More cardiologists are headed that direction. We hear it from our patients where, yes, my cardiologist is starting to listen. More of them are aware of this channel. More of them are saying, you know what, it makes sense. But if yours hasn't yet, there's not a whole lot we can do about that.
If your cardiologist is a 300-pound lipidologist, don't mention Dr. Burr. Bill Kearney, the standard story is if you lower ApoB, there are fewer particles available to enter endothelium space. Does quality matter? For example, type A versus type B, as described by Ron Cross. Really in-depth question to discuss. We can do a whole show about this. To me, the short answer is it matters, but it doesn't matter as much as inflammation. So
really good point. And I just have to jump in and say the same thing. It's the same thing about LDL. This stuff up here says LDL never matters. And I don't agree with that. It's like the example you brought up and we covered, the 8-year-old having a heart attack. And the only thing we could see that could be seen was a really high LDL. So I wouldn't say that LDL never matters. I wouldn't say that ApoB never matters, but it's
individual because you're individually, everyone's made up differently of different cells. So I think you have to look at the whole case scenario, right? Each time.
You do. And we're stepping over gold mines in terms of pathology to look at a penny. You know, we're stepping over people that they're metabolically a disaster right now, and we're wanting to look at LDL.
Yeah, exactly. There are more things to take a look at before just focusing on that. And you have a lot of people pushing on ApoB and decreasing ApoB, and we're not saying do not do that. We're saying if you're gonna do that, also do other stuff that's gonna save your life, other than just decreasing your ApoB and LDL.
Yeah, because ApoB and LDL go hand in hand, so it's the samesies, just in a different stage, right? Pretty much.
Peggy Douglas talking about the YouTube ban, and carotid ultrasound, the same as the CIMT. It's not the same. CIMT uses ultrasound technology, but it's in a specific measurement that not all carotid ultrasounds will do.
And you're exactly right. Oh, I'm sorry. Go ahead, Jesus.
I just want to wrap up the YouTube members' questions. Looks like I'll need to educate my doc, as a lot of our patients do.
Yeah,
they
you're
educate
exactly
their
right.
doctors on this. So that's the way it is.
Most doctors think it's the same thing, and it's not.
And the last thing I want to cover, this is just to boost my ego, Dr. Brewer.
Well, that's important. We got to boost Jesus's ego.
No, I just want two purposes. Well, JMK is one of viewers that she's not a. It's not a. I'm again. It's not a YouTube member. It's not a YouTube member, but interacts a lot with us. So this is the bottom line for the show. For a lot of the show, the reason of getting a coronary CT angiogram is to tell how much soft dangerous plaque you have, and therefore tells you how well you're doing in slowing or stopping your inflammation cardiovascular risk process.
Did you want to read your name in that? Jesus?
I already said that. Okay. Between the lines.
I think he's exactly right.
So, anything else to add? I know Jeannie has an appointment in about 10 minutes. So,
I do.
Really good show, Dr. Brewer. Anything you want to close? Any final thoughts? Any final
no, thanks. I had a blast, and I hope we did provide a good experience for people learning a little bit deeper dive on cardiovascular prevention and disease. Thanks.
Sounds good. We're excited now about David Feldman's research, Dr. Brewer.
Absolutely.
I'm waiting for that article to be published.
I am too, but I think it's going to be at least 6 months, maybe longer.
Well, if they pay, probably faster. You know how that works as well.
Yeah, but that ain't going to happen. You know how academics are, and they're going to go through an academic group.
Yeah, it is. All right. Okay, see you next week then. Thank you, everybody. Bye-bye.